Ladies and gentlemen, thank you for your patience in holding. We now have your speakers in conference. Participation in this conference call is by express written invitation of the AHA only. Unauthorized participants and or any party that assists unauthorized participants may be subject to substantial criminal and civil penalties. If you've not been invited to take part in this call, please disconnect at this time. Please be aware that each of your lines is in a listen-only mode. At the conclusion of today's presentation, we will open the floor for questions. At that time, instructions will be given as to the procedure to follow if you would like to ask a question. It is now my pleasure to turn today's call over to Chris Hunt. Sir, you may begin.
Thanks. Hi, everybody. Welcome to the March TeamSTEPPS monthly webinar. This webinar is on coaching, and it's entitled Coaching Teamwork Behaviors, Strategies to Reinforce TeamSTEPPS Skills. So I'm very excited about this. Our colleagues from Carilion Clinic in Roanoke, Virginia are on the call, and they were one of the original TeamSTEPPS Master Training regional training centers. So a lot of great history and rich understanding of TeamSTEPPS. So definitely looking forward to having them with you today on the webinar. An announcement before we get going. We're having significant difficulties with our vendor with technical difficulties right now, and for some reason it seems as if most people are unable to log in to view the webinar, including myself actually. So if you hear me say next slide please, that's because somebody else is doing the slides for me and I'm just looking at a hard copy right now. So what we're doing about this is we are making a recording of this like we always do, but we'll be distributing it to those that could not make it because we're definitely having a large number of people who are not able to join us. So sorry about that, and for those people listening to this webinar at some point in the near future, my apologies that this is going on with the technology. Okay, next slide, please. So some of the rules of engagement for today, just to let you know, for those of you that have been able to join, the audio for this webinar can be accessed in two different ways. So you can listen through your phone, and some of you might be listening just through your phone because you couldn't sign into the computer. And if you are listening through the phone, please make sure to mute your computer speakers. So there is a green button near the top of the screen you're looking at, and you could mute the speaker there. It cuts back on feedback since you're listening through the phone. You can also just listen through your computer. The caveat to listening through your computer is that if you have a question and want to ask it later on and we open it up for audio questions, obviously you wouldn't be able to do that. We will do a Q&A section at the end of the presentation, and what we really encourage people to do is to write in questions using the chat function you see on your screen. The reason we ask people to submit questions this way is because it allows us to craft a coherent question and answer session that follows some general themes. This means, of course, that some people's questions don't always get asked, and it's not that we don't want to ask them, it's just that they didn't maybe fall into the themes that seem to be generally coalescing around certain topics. We do, however, make sure that those questions, any questions that are asked through the chat function, are answered and then posted later on the website, teamsteppsportal.org. If you also want to ask a question and you're listening to this as a recording, what we encourage you to do is to send the question into AHRQ TeamSTEPPS at AHA.org, and this email address will be on screen later on. And what we'll do is we'll be able to forward those questions to the presenters. So sorry for all of the problems today. Next month will definitely be, hopefully the technology will be fixed with the vendor. All right, and we might open the lines for call-in, dial-in questions later on. It is kind of depends on how many chat questions we get, and so we will let you know about that later. Okay, next slide, please. So you should be looking right now at some acknowledgements. We always like to thank Dr. Jim Battles, who is from the Agency for Healthcare Research and Quality, as well as Heidi King from the Department of Defense. Jim and Heidi were the people that really led the initial push for TeamSTEPPS, the creation of TeamSTEPPS before there even was a program. And Jim and AHRQ are currently the people who lead the civilian side of this and who fund everything, and that's actually who I am funded by and my organization is funded by. We're the Health Research and Educational Trust, and we're part of the American Hospital Association. And AHRQ provides us funding to run these webinars, to run master training courses around the country, the TeamSTEPPS National Conference, and also the creation of new content. I'd also like to thank Impact International, David Baker and Andrea Amadeo, for their work and their team's work on TeamSTEPPS. They've been partners with us for many years, and we always look forward to working with them. Next slide, please. Okay, so TeamSTEPPS Master Training Courses, something that we offer. I always like to advertise at the start of a webinar. We have 2-day master training courses that are train-the-trainer approach, which means that you come in and you learn how to go home and teach TeamSTEPPS to others. But we also like you to wear the hat of how to serve as an implementation leader within your organization. And so I think that that's a very great part of our courses, because people come in with a problem, we help refine that problem, and we help pick out which TeamSTEPPS tools can be useful in working on that problem. So TeamSTEPPS Master Training courses not only teach you how to teach, but perhaps even more importantly, teach you how to work on a quality improvement project in your setting using TeamSTEPPS. All right, next slide, please. So monthly webinars such as this, scheduled through September 2015. Right now you can register for the April webinar, which is TeamSTEPPS for Code Blue Teams, piloting SPHR, and CUS for interprofessional team education. So those that webinar, as well as many others, will be taking place this year. You can register for master training courses through August 15 now. And if you're not able to attend a master training course, there is an online course available. And if you head on over to the web link that we have there, the URL, https://tslms.org, if you go over there, you could register for this course. It goes through the same content, just in a different style. It's all online, and you can work at your own pace, and obviously you don't have to expend any travel dollars. Next slide, please. We also have the annual conference, which registration is open for now, June 16th through 18th in Denver. Always a lot of fun. It's entirely put together by people from the TeamSTEPPS community. Everybody turns in proposals for what they want to present about. So what I think is interesting about it is oftentimes people that have come to a previous conference, gone to master training courses, then come back in a year or two to present at the good work they're doing. So there's something for everyone. It covers people from beginner levels. We have TeamSTEPPS 101 presentations all the way through advanced levels. We've got a lot of interactive workshops this year, more than last year. I think there are 8 different workshops you can now attend. And I just think that it's a great networking opportunity. You have this ability to talk with people from around the world who are interested in TeamSTEPPS. So definitely consider coming. It's a free conference, just like everything else sponsored by AHRQ. All you have to do is pay for your travel and your hotel room. So to learn more about any of these things, TeamSTEPPSportal.org is where you want to head over to. Next slide, please. Okay, the helpline, very important on today's call, especially because of the technical difficulties. That email address that you see on screen right now, AHRQ@aha.org, that's the place you're going to want to send questions you might have if you're listening to this as a recording. If you're on the live version right now, one of the lucky few, please make sure to use that chat function I spoke of earlier that you see on screen. Okay, next slide. This will be the last you hear of me. I'll be turning it over after this slide to today's presenters. Like I said, they're all from the Carilion Clinic, which is in Roanoke, Virginia, and one of the original TeamSTEPPS regional training centers. I'm very happy to introduce Charlotte Hubbard, who I've worked with for some 4 years now. She's a senior education consultant as well as a master trainer at Carilion. We've done lots of fun things together around the country, teaching many people about TeamSTEPPS. So I'm glad to have Charlotte here today. Also, Kris Peters, a nurse and the emergency department clinical educator at Carilion Clinic, and Sheila Lambert, the Senior Director for Pediatric Services at Carilion. So as you can see, we're definitely hitting many different parts of the hospital today and got a lot of good expertise coming in. As I turn it over to slide 9 to talk about the objectives, this is where I'd like to turn things over to Charlotte, Kris, and Sheila. Thank you.
Thank you, Kris, and thanks for the chance to be with you today. Our objectives for the webinar, as you can see, are to describe the role of a TeamSTEPPS coach, describe strategies for effectively coaching some TeamSTEPPS skills, and look at some examples of coaching strategies and support that Carilion Clinic has used during their implementation efforts. Just as a note, I'm using introductory information from the instruction on coaching that's usually provided in the TeamSTEPPS Master Trainer course. So for some of you, the information about what we mean by coaching and the role of a TeamSTEPPS coach will be refresher. But for others, this will be new information and it will help set the stage for the specific examples that Kris Peters and Sheila will be describing to us later on in the presentation. Next slide, please. You've heard of coaching in lots of contexts: sports, personal development, life coaches, leadership, public speaking. But coaching in an instructional context is a specialized form of communication that supports newly learned behaviors. Instructional or skill coaching might include instructing, it might include directing or prompting. You may see a coach demonstrating skills, reinforcing their use, motivating the learners, and providing some direct feedback. Effective coaches are always focused on goals, the goals of the team and the goals of the individuals being coached. Coaching is different from traditional instruction. With traditional instruction, teaching typically ends when the content's mastered, or you at least think it's mastered. In coaching, however, you continue to support individuals and teams even after the content or skill is mastered so that you can ensure sustainment. Next slide. Providing skills coaches after TeamSTEPPS training reinforces and actually refines the learning, brings a deeper understanding of the concepts as the skills are applied. Coaching uses different components. It uses relationships, it uses feedback, it uses modeling, simulation, and it offers a just-in-time learning opportunity in real situations. Coaches act as role models, and they're available to debrief in critical moments when skills have been applied or maybe could have been applied to create a safer patient outcome. Any organization that invests in coaching new TeamSTEPPS skills is actively demonstrating that the new behaviors are valuable and expected. Next slide. So, should you choose to use coaching to support your TeamSTEPPS implementation, what can you expect to happen? Well, with effective coaches in place, you really clarify the learning goals for the individuals and for the teams. What do we need to know and do differently? You align behavioral expectations so that every team member understands what should be done in certain situations. You can identify unanticipated barriers to using the new skills and processes. With coaches directly involved with the team, their frontline knowledge of what's going on can really identify barriers to implementing your new skills. And you successfully integrate the new behaviors in daily practice. When coaches are in place within the teams, they are able to monitor teamwork behaviors and ensure the continuing use of the skills, not just the using them when they're new and shiny. An added benefit is that they're more easily able to see opportunities for new areas of improvement, adding a new skill or approaching situations in a new way. So TeamSTEPPS coaches can be crucial to both implementation, startup, and sustainment efforts. Next slide, please. So who might be an effective coach? Well, there are lots of formats to delivering coaching in a skills setting. You might use your TeamSTEPPS trainers as coaches. When Carilion trained several of our AHRQs, we developed trainers who are already members of that unit to go back and train their peers. You might use peer coaching, where other team members with good skills are accountable for supporting new behaviors. They're embedded in the team. Sometimes formal or informal leaders, like charge nurses or preceptors, are access coaches as part of their formal role. Or you might even identify an individual who is especially good at a specific skill. A skill-specific coach has a great grasp of the skill set being implemented on their unit. They focus on coaching just that skill, bring it to its full usage, and then coaching duties may shift to other individuals on the team as new skills are added. There's just a variety of approaches. These that I've just mentioned have the added benefit of ongoing relationships and kind of a native understanding of the work area and the area's unique culture. I have seen external to team coaches be effective, but just be aware that the white coat and clipboard syndrome, where a person arrives to coach who is seen by staff as unrelated or uninvested in a specific unit. If you choose to use external to the team coaches, they need to be very invested in the team and make that well known to the team members. Next slide, please. A TeamSTEPPS coach is expected to role model behaviors, observe and provide feedback, be a motivator, and provide chances to practice and improve. So let's look at each of these in a little more detail. Slide. Modeling teamwork behaviors being trained offers more than just a demonstration of the behavior. It highlights the acceptance of the behavior and environment. The coach's presence itself can be a constant reminder that the new behaviors are expected. Oh, here comes Charlotte. I'd better learn to cuss. All right, next slide. Feedback is best delivered by coaches or by anybody in the context of a respectful relationship. In addition to the right motivation, timing, and environment, make feedback more effective, in addition to the right motivation, timing and environment make feedback more effective and likely to be heard. So to succeed, your coaches probably need specific training on giving and receiving feedback. In that training, you might want to provide the coaches with a specific structure or model for providing feedback. For example, SMART feedback. The SMART feedback model structures feedback that's specific, measurable, attainable, realistic, and timely. If your organization already uses a feedback model, maybe in performance management or communication classes, teach the coaches to use that same model that's in place in your organization. At Carilion Clinic, we use a model that's represented by the letters SBIA, the SBIA model for feedback. The letters stand for situation. What's the situation you've observed? The behavior. What behavior are you targeting? The impact of that behavior is the I. And then as a conclusion of the feedback, ask for action on the part of the person you're giving feedback to. So pick a model, teach the model, and it gives coaches a great structure to follow through with feedback. Next slide, please. This slide, Coach's Motivator, really describes the real work of the coach. That's to encourage the team and individuals, to validate and give feedback, to pay attention so that the coach notices and supports people's efforts, and not just efforts, but intent. Not just their successes, but their attempts and acting as a champion by communicating positive results. You can see that successful coaches have to be special individuals whose work takes energy and focus and really consistent team-oriented perspective. Next slide. In some environments, chances to practice TeamSTEPPS skills might not occur frequently or might only apply to some team members and not consistently across the team. So the role of offering frequent opportunities to practice behaviors is critical to integrating and sustaining your new TeamSTEPPS culture. Here's some examples of opportunities to practice. Debrief in important events with the teamwork skills in mind. Using scenarios during staff meetings, talking about what happened across the last week. Developing resources that are tailored to the unit and to the unit's goals. And then bring in that ever-present physical reminder that TeamSTEPPS tools are expected to be used. In conjunction with ensuring that the skills are practiced and that people have opportunities to try, coaches may also wish to reward the attempts or the effective use of TeamSTEPPS. For example, coaches might design a contest to encourage more frequent use of the tool, or they might recognize the great catch of the week, or bring more and more opportunities to try in place until the mastery of the skill is certain and they're ready to move on. So next slide. So coaches are a human element in reinforcing the new behaviors. You as a leader and as a change champion can create opportunities to encourage and reinforce a new skill using the physical environment as well. For example, some of our operating room sterile packs include a bright orange sticker with the steps for debrief in the pack. So it's right there on the sterile field. They pull it out and follow the steps at the end of this procedure. Be creative as you think of the physical environment. In Carilion's trauma bay, there are boxes marked with yellow tape on the floor. Each role in the trauma response team has a designated box in which to stand. Because acting appropriately in the team role is so vital to the success of a trauma code, when the boxes are full, the extra people in the room are expected to leave. So think about your physical environment and how it supports the use of the tools that you're implementing. Next slide. Whoever you choose as coaches, be sure they have an opportunity to learn the skill sets that you see here on this slide that will be required for them to be effective. Sure, they need to know the TeamSTEPPS tools and have some expertise there. But they also need skills in communication. They need a good understanding of performance improvement and how change happens. They need excellent relationship skills, and they need to be good implementers, able to not fall by the wayside when the follow-through has to happen. So as a resource, look at the training that's already available in your organization. Chances are good that you have access to learning opportunities for things like communication, feedback, maybe even the performance improvement process that's used across your organization, and especially in conflict resolution. These topics don't have to be part of your TeamSTEPPS training plan, so don't feel like this is adding a burden to your curriculum. Chances are very good that you can access this before you begin your TeamSTEPPS implementation or in conjunction with it as part of your readying the culture for the change that's to come. Next slide, please. When you choose your coaches and train them and put them in place, don't forget to support them while they're there. Select coaches who are well respected and supported in their work area who can consistently demonstrate the behaviors that they're working to improve and reinforce, and then support them with a clearly defined coaching role so that everybody understands what the coach should be doing and not doing, and then give them a clear definition of the skills and information that they need to build their expertise, not just in TeamSTEPPS, but in coaching. Next slide, please. Also, offer your TeamSTEPPS coaches and their teams support by doing those organizational things that support their efforts. Look at your policies and processes. Maybe a simple editing or adapting of a process would support their efforts. When you're willing to do that, this demonstrates valuable organizational buy-in. Coaching can be, in addition, coaching can be a lonely and actually sometimes risky work. So offer chances for your coaches to network with each other, to share their stories and share their successes. Don't forget to recognize and reward your coaches and the teams they support. Publicize their success. Let everybody know how well it's going and the contribution that your coaches make. We are very fortunate to have two experienced TeamSTEPPS leaders from Carilion Clinic to tell you about their coaching during implementation. First, we'll hear from Kris Peters. Kris is our emergency department clinical educator, and she has a great story to tell about a long in place and ongoing program in our emergency department. Next, we'll hear from Sheila Lambert, who's our Senior Director for Pediatric Services. So thank you both for being here and sharing your time with us today.
Good afternoon, everybody. I'm Kris Peters, and as Charlotte said, I'm the clinical unit educator in our emergency department. I'm actually one of three of our educators in the department. I did want to tell you a little bit about the emergency department. We are an 80-bed Level 1 trauma center. We have a dedicated pediatric emergency department. We see about 230 patients a day, and we have all totaled 300 FTEs. Next slide, please. TeamSTEPPS in the emergency department has been taught to all nurses during their orientation. Our providers actually attend an annual non-mandatory training, and our ED residents receive the training during their first year of residency with us. Our coaches are our clinical team leaders and our Trauma Nurse Academy graduates. And these were selected, and we'll talk about how they were selected and why they were selected as we go through. Next slide, please. Clinical team leaders are actually hired into their position, so they always tell us they were voluntold that they were going to be coaches for lots of things. Our trauma nurses, however, are nurses that have been in our department for greater than 18 months, have excelled in their practice, and they actually go through an application process into the academy, and then once into the academy, they receive special education and training in order to be primary nurses in our trauma bay, and they are natural coaches as they are our most experienced and senior staff members. We do support our coaches and our team leaders through monthly meetings, retreats, and one-on-one meetings as necessary. Next slide, please. What I wanted to tell you today is that implementation takes time. When we began this process in 2007 in our emergency department, we added it into a trauma course that we taught to everyone who starts in our department. And we added in 2007, and that is how all of our nurses were taught that time during that one class. We found, however, that up until 2 years ago, you could ask any of our staff members about TeamSTEPPS, and they really didn't know what we were talking about. Yes, they knew the terms, huddle, debrief, cuss, but they didn't know the phrase TeamSTEPPS. So we stepped back. We stepped back and we said, you know what, we just really can't give up. We're going to use the terms. We're going to use huddles. We actually have changed our morning meetings and our afternoon meetings to huddles. We talk about brief and debrief. We laugh at the phrase of cuss, but we use cuss into challenge, and we just said we weren't going to give up. Next slide, please. And by not giving up, we educated again. In this picture, those that you can see it, this is Stephanie. Stephanie is one of our clinical team leaders. Stephanie is also a new master trainer, and she's actually teaching TeamSTEPPS to our Trauma Nurse Academy. And placing, as Charlotte said, picking coaches that are invested in your team is so important. And when staff see staff and they teach and role model the things of TeamSTEPPS, it really ingrains it more than myself or even another one of our leaders talking about that. So don't be afraid to educate again. And don't think this is something you're going to do just one time or just once a year. It is actually something that we have to do continually in order to ingrain the skills that you want them to have into their daily practice. Next slide, please. Also involve physician champions. One of our lessons learned in the emergency department was that when I told you that we taught this to everyone in their trauma class, what wasn't happening is that respiratory, lab, x-ray, our physicians were not being taught TeamSTEPPS. They had a program when we first started where the residents and our trauma team were being taught. That kind of stopped for a while, and we recognized that if not everyone in the room is playing in the same level field, really nothing was getting done, and chaos ensued. So when we began the Trauma Academy, our physician champion, and actually Dr. Collier is one of our, he's our chief of trauma surgery. He actually teaches in our classes for us as well, and he upholds probably one of the best role models for his residents and his trauma services as far as TeamSTEPPS is concerned and his leadership within that room. It's very important. In the emergency department, both of our pediatric physicians are master trainers, and 3 of our adult physicians are master trainers, and they teach those classes along with our nursing staff to the new residents and to the physicians every year. Next slide, please. You do want to provide simulated practice, and in the emergency department, we do things a little bit different. We have multiple opportunities in our department to where we real-time have critical situations that occur, and so we can debrief those. But what we have found also is in our play, when we have our play time, we want to use those times in order to have some great outcomes from those. So we use many different opportunities to practice TeamSTEPPS, and one of those is we do trauma simulations with our classes. And so in the simulation lab, whether we do that in the trauma bay itself or actually in the lab, we use scenarios that cause the participants to use their TeamSTEPPS skills. We debrief after the first one, and then we go in and do it again for them. We actually will do 3, and we call it the good, the bad, the ugly from those. And so they get to debrief and figure out what they did and what they can do better. We also use simulated training in our advanced courses, and we use it in our skills days as well. Staff will either do a simulated patient with one of the mannequins, or they will use a tabletop type of simulation with that and go through those. And so those are extremely interesting and very well received. Our staff in the emergency department are very kinesthetic learners, and so they like getting their hands into things, and they learn so much better when they're participating in their actual learning. Next slide, please. You do want to take your team out of their comfort zone, and so when you're thinking about your simulations, we tend to try and stay around what we know and where we work. And so it's really important to take your team away from what they know in order to bring about some advanced skills or some skill sharpening with them. And we do that quite often with our staff and take them away from what they like. Our particular staff, we enjoy we don't know what's coming in the door the next minute, but we do not like change when it has to deal with our environment. And so when you shake up the environment a little bit, sometimes learning occurs greatly. Next slide, please. Probably one of our biggest things that we've had to get used to as a clinical staff is that successful teams don't always save the patient. And so you want to measure your success not by the patient outcome, but by the communication and the team outcome in the room. This is actually a picture of our trauma bay for those that can see it, and Charlotte referred to the boxes. There's probably 20-some people in front of the camera at this particular point. There's X-ray, there's lab, there's some scribes, and then there's surgeons and residents and whatnot at the bedside. We are a teaching facility, and so at any given moment we have orientees with us. Everybody has one, it seems. And so there are a lot of people. What you don't see in this picture is chaos. What you don't hear in this picture is there's actually silence in the room, and one person is speaking, and there's call out and check back occurring. And this was actually a real patient that you can't see naturally. But what struck me about this is the silence in the room and the control that was occurring during this actually trauma resuscitation that was occurring. So when you think about your TeamSTEPPS and you think, well, I don't know if they'll ever get this, our outcomes aren't good, don't think of it that way. Think of it as this particular incident occurred really well. This wrong medication was ordered and the nurse used cuffs and to challenge appropriately and the wrong medication wasn't given. Whatever that situation is, when you use those things, count those as successes, not necessarily in the patient realm for us. Next slide, please. I'm very happy to turn the mic over to Sheila Lambert, our Senior Director of Pediatrics.
Good afternoon. As Kris said, my name is Sheila Lambert. I'm the Senior Director for Pediatric Services at Carilion. And just to tell you a little bit about our service area, we have a 60-bed Level 1 NICU, a 24-bed inpatient pediatric unit with an 8-bed PICU. We have a full-service NeoPeds transport team, 18 outpatient clinics with numerous satellite clinics serving the outlying counties, and a full complement of pediatric specialists such as genetics, neurology, pulmonology, and so on. Next slide, please. One of the things I'm thinking about as the three of us are sitting in this room, Charlotte, Kris, and I all come from different settings, but we each use these tools and make them work for our own areas. So regardless of what your specialty is or what your service area is, these tools, you can create them to work for you in your environment. So I wanted to talk a little bit about coaches. I put on the slide core group, champions, master trainers, coaches, because we've been doing this work for about 6 or 7 years now, and we've called them all sorts of different names, all positive names, of course, but today we'll refer to them as coaches. One of the important things about picking your team before you start this work is looking at your informal leaders. At times, your informal leaders can be more successful change agents than the formal leaders, so you want to assure their commitment to this process from the beginning. You want to do a lot of pre-work before actually rolling out this work to your group, so you look very thoughtful in your approach. Our coaches are from a multidisciplinary approach. We have physicians, nurses, respiratory therapists, pharmacists, unit directors, and nursing assistants, so that we're all sort of speaking the same language. I believe Kris approached that as well. If it's just nursing or just physicians and they're saying things like SPHR and cuss, people are going to think they're in a foreign land, so we all have to use the same verbiage. Want to have transparency up front when we pick our coaches. Be realistic about their level of accountability to this change, the time that may be involved, the responsibilities, which would include at times maybe having crucial conversations with your staff. I noticed you did this. It might have been better if you'd approached it through SPHR, those kind of things. Have people with the ability to have those conversations and just a real commitment to the process. If your coaches are not committed, the entire credibility will be at risk. So that's really important to think about. Next slide, please. Not only do you want to start this off with a bang, but we also want to sustain this in in healthcare in particular, we have lots of different items coming to the forefront, lots of priorities, kind of flavor of the day things. So we want to make sure when we present this to our team that they understand this is really how we're going to go. This is for the long term. This is not the hot topic of the day. So what we did in pediatrics was we did a lot of advertising up front. TeamSTEPPS tips of the week with candy. Everything always gets better if it's got candy on it. We had notepads everywhere that said TeamSTEPPS just for that subtle sort of advertising, keeping it in the frontal lobe. All things penguins. Penguins are sort of the symbol of TeamSTEPPS, and so everywhere you look there were penguins, little stuffed penguins. And because my area is pediatrics, we could really kind of go silly with it and expand on that, which was a lot of fun for the staff and our patients and families. We bought TeamSTEPPS badge pins. We have hang-down badges at Carilion, and we have little things we can put pins on, so we all had TeamSTEPPS pins. Our champion or coach meetings were every 2 weeks, continued to this day, but not quite to that regularity because, like I said, we're in our 6th or 7th year now, so we don't need that constant sort of momentum anymore. It's sort of the way we do things now. The important thing is that staff realize it's not a passing phase. It's our model for patient safety moving forward, and that's the big thing. It is about patient safety. Next slide. A couple of the ways that we also encourage staff to go with this way of thinking, encourage the sustainment was we try to get all of our email communications, at least from leadership and administration, in SPHR format so that the staff sees that frequently. And this has gone a lot of places through the house, through the hospital now with pharmacy and different disciplines doing this so that it's in the SPHR format, very clear, concise. For those of us who get inundated with emails, 100, 200 a day, succinctness is the key. I'll tend to just skim at the end. If someone gives it to me in SPHR, it's very valuable, and my group feels the same way. Our physicians actually have gotten to the level of if a nurse calls them with an issue about a patient and they just start sending the information, the physicians will say, can you give that to me in SPHR? It's very helpful for them. They get what the nurse is recommending at the end. It's very helpful. So they have stopped the nurses before and said, let's pull back and give that to me in SPHR format. We talk about TeamSTEPPS in some way at every staff meeting. It may be just something simple, but we really try to catch them doing the right thing. We try to illustrate some things that have transpired that they did use the TeamSTEPPS tools and had successful outcomes. We try to come at it from a positive approach versus we could have done this better, and that seems to be very helpful for the staff. Next slide, please. If you can see the slides, this is one example of something that we will hand out to our staff, and it's just a piece of paper that says the TeamSTEPPS standing ovation goes to, and you fill in the person's name, for excellent communication strategies and tools to enhance performance and patient safety, has the date on it, and a little dancing penguin. For those of you who can't see it, it's really cute. But the point is, this is something that the staff can hold on to. They have documentation of this for their evaluation time. It's just a really good tool, and my groups tend to like things they can hold on to, much more than just a, hey, good job, but something that they can look back on and have a sense of pride about. Next slide, please. So this is a variation of the other one that I just shared, but this one has a little bit more detail, and we use this one a little more in the beginning. So same thing, a TeamSTEPPS standing ovation goes to whoever the name is, for using excellent communication skills, strategies, and tools to enhance performance and patient safety. Here's how you implemented those tools. So we'll actually write down, one of the coaches will write down exactly what happened with the date. So in the early stages, when you really want to get that message out there, we would post this so other staff can see it. Oh, well, I could have done that, or, you know. So this is very helpful in the learning phase, or with your new hires. With the turnover we have, we're constantly re-educating for the newer group, but we do have the seasoned folks as well, so it's helpful. Next slide, please. As I said, the key to this process for us was the sustainability. I think the low-hanging fruit is getting something off the ground, but to really make that part of your practice and the way you approach your care is the key. That's the golden ticket. And so, you know, to Kris's point and Charlotte's point, sometimes we do 2 steps forward and 1 step back. You know, we think we're really getting somewhere, and then there's something that happens, an event or a conversation or communication that makes us sort of step back and say, ooh, we probably could have done better with that. So we just have to, overall, to keep moving forward, keep the good work doing, and keeping that change team, coaches, and staff motivated so that we don't have the drift. So often after a while we drift, and it's important to illustrate how this really helps us with patient safety and patient satisfaction, honestly. So that's all for me. I'm going to hand it back to Charlotte now.
Thank you, Sheila. And thank you, Kris. Great illustrations and a lot of work represented in what you described to us. So thanks very much. Well, looking back at both these examples and other experiences we've had around Carilion Clinic, I want to reflect on some of the lessons that we've learned in using coaches. Choose your coaches carefully. Who is coaching can make all the difference in how the coaching is received. So choose your coaches carefully. Multidisciplinary training and multidisciplinary teams will allow for cross-discipline coaching. This is highly effective. It can be incredibly effective to have the person who's directly affected by your behavior give you some feedback. Don't hesitate to reteach if reteaching is indicated. Don't hesitate to stop the action, take a pause, and regroup. And coaches can help you identify these learning needs, the things that need to be retaught. Coaches can help you identify these early on. It's really valuable to use TeamSTEPPS language on the unit and in the broader organization. Role modeling the behavior just communicates very strongly that the behavior is expected. So encourage using TeamSTEPPS language in the broader organization. Spread the tools to non-clinical applications. Again, this models the behavior and engages your non-clinical staff so that patient safety doesn't just become a clinical thing, that clear communication and team support make a difference in all our work. Don't forget to use a physical environment. Both Kris and Sheila have some fabulous examples of using the physical environment to communicate expectations. And these little physical reminders actually are nonverbal coaching. Sometimes a visual reminder is all it takes to encourage that new behavior and to keep it in place. And as a final thought, the active coaching takes skill. It's hard work. It involves some risk, and it's essential to your initiative success. So go out, choose, train, support, and reward your coaches for the hard work that they're doing. Thank you. So, Kris, we're ready for questions if you have questions.
Thanks, Charlotte. And thank you also to Sheila and Kris. Really enjoyed that. I appreciate it. You guys really did soldier through even though the technical difficulties, so I appreciate it. So as far as I know, we have not had any questions chatted in. So I'd love to open up the questions to folks who have called in, who want to ask their question verbally. Just please remember, if you're listening through your computer speakers, you'd have to dial in to ask your question. So, David, if we could open things up for audio questions, that would be great.
Thank you. At this time, we will open the floor for questions. If you would like to ask a question, please dial the star key followed by the 1 key on your touch-tone phone now. Questions will be taken in the order in which they are received. If at any time you'd like to remove yourself from the questioning queue, please dial star 2. Again, to ask a question, please dial star 1 on your touch-tone phone now. Our first question will come from Tina Adams of AHRQ. Please go ahead.
Hi, thank you so much. I thought this was a terrific presentation, and I really appreciate the case scenario setup of it. I did want to ask the presenters, because you've been on this journey for a while, I would like to ask if you would say just a few words about, if you knew then what you know now, how you might plan or implement your process differently. What did you learn along the way that you wished you'd known sooner so it would have affected your implementation plans? Thanks.
Thank you, Tina. This is Charlotte. I wish you could see the thoughtful looks on Kris and Sheila's faces.
This is Sheila. I can just say something real quick, lessons learned along the way. I started this out on PEDS and PICU, which is, PICU is a relatively small unit, 8 beds, and I took this very successful approach and said, well, if it works here, it's going to work in this massive 60-bed NICU, and it didn't. And so I think it's really important to know your staff or your area and what would work best for them. For instance, starting with this tool in this area might not be the approach you would use in the next area. So I actually, trying to take this cookbook approach, probably set us back a little bit in the NICU and had to gain some ground back. So I would just say, really know your area and what will work best for you. Kris?
Yeah, that's very true. The emergency department setting in itself, we rolled the TeamSTEPPS out into the trauma bay only. And so staff only used the skills in the trauma bay. They would be out on the unit and have a situation occur, and they would not infuse the same skills that they just finished using in the trauma bay because they said, oh, we only use it in there. So use it throughout the department. And really, I don't know if anybody else has staff like our department has staff, but they don't really accept things well when it's the flavor of the month and they think, oh, this is just going to go away. And so you really do have to, it truly is. If I had known then to use the phrases of, this is really important for patient safety, this is why we're doing this, even though it's all about patient safety and we talk about that, we had to give them real examples of when do you use these things. And so the true simulations and the more and more simulations that we run and the more and more they watch, we videotape all the simulations as well, so they get to watch themselves after, and there's some pretty funny ones. And then we share those, and so they laugh at each other all the time about something they've done, but yet those are the times that we learn the most.
Yes, I agree.
So don't be afraid to just, you're going to take a beating, I think. If I had known that we were going to take the beating on some things that we took, I'd have said, let's just not do this.
I agree.
But just sustain the beatings, and eventually they'll begin to cuss at you and not use bad language.
Well, and I find that the comments that were made about sort of, I'm going to call it marketing, and that it's embedded into the meetings and all the different places that were described where it's brought up and discussed. I think that eventually the staff see that it's not going away, and that is your sustainability plan.
Yes.
Agree.
Agree. Yes. Right.
Yeah.
Thanks for your question, Tina.
Thank you for your question. As a reminder, if you have a question, please dial *1 now. Our next question will come from Marianne Bone of THHEB. Please go ahead.
Hi. As a team coach, we have implemented the process and are using the terms, but one thing we're struggling with is differentiating between huddles and briefs. I was wondering if someone could clarify those two terms for us.
This is Charlotte. If you want to get truly technical, briefs are planned pre-event or pre-procedure, and huddles are unplanned at the point of time when a patient condition changes or you get new information. But if you want to get really technical, it doesn't matter what you call them as long as you do the same thing in the event, in the communication event that you're having. You can call them purple and green. But Kris and Sheila might have some additional things to say about that.
Actually, for us, this is Kris. For us, we use the term huddle. Our shifts begin at 7:11, 3, 7, and again 11 p.m. And at every beginning of every shift, our team huddles. And so that's a planned event for us, so we should be calling it a brief, but we've called it a huddle. And our staff do that. They actually get together and they're told about what's going on in the department, how many staff we have, what areas we call it potted or not potted, who our physicians are for the night, and then they're also given education during that time, whatever the 3 or 4 things. So we do call those huddles. During the shifts, and our staff have actually taken, because we have 20 and 30 staff coming on at the big shift changes, the little tiny shift changes, they call those cuddles, because they cuddle up instead of huddle up. And then we brief prior to whether if there's a code coming in, or we're going to do a sedation, or there's a trauma. We brief before those to get the patient information and who's doing what. So just like Charlotte said, you can call those things anything you want to call them. One thing we do not do well in our department is debrief, because in those critical situations, our patients are gone typically. They're taken to the OR or they have passed, and we really, and I'm going to use the phrase stink, we stink at debriefing. So that's one thing that we don't do well, but it is true. Pick something you like and call it that. It took me 2 years to get them to huddle. And so and I wanted to huddle as the day was going on, but once they started calling the morning meeting huddle, I celebrated.
We're pretty much the same way. As long as you do it, the name is whatever works for your staff, but we call it huddles as well.
Does that help?
Yes, it does. Thank you so much. I do like the cuddle.
I like that. I hadn't heard that either. That worked great on pediatrics.
Yeah. All right. Thank you.
Thank you for that question. That is all the time we have for questions today. I'd now like to turn the conference back over to Jen Braun.
Hi, everyone. So since we're at the top of the hour, I want to be respectful of everyone's time. So I want to thank you all again, despite the technical difficulties. And more so, I'd like to thank our 3 presenters, Charlotte, Kris, and Sheila. Thank you so much for taking the time out of your day to present this very important topic. Those who are listening and watching to the recording that we will send out, if you have questions for the speakers, please email us, and we will send that to them and get your question answered. The email is arcteamsteps@aha.org. That's AHRQ teamsteps@aha.org. So thank you again, everyone, and have a great rest of your day.
Thank you, ladies and gentlemen. This concludes today's conference. You may now disconnect your lines, log off your webinar, and have a great afternoon.